Well, hello, everyone. Thank you so much for coming here. I want to start today by saying I hope you know that it is Pi Day, 314. So I just wanted to get everything started off on the right track here. Thank you so much for taking time out of your day to come to this talk, supported and sponsored by Roche. Today we're going to talk about the Ventana folate receptor diagnostic assay, where it comes into play with patients with ovarian cancer, a little bit about that. So first, I will give you the agenda for the next hour. I'm going to introduce myself momentarily. We'll talk about the mechanism of folate receptor-alpha, who it should be considered for, when to use the testing, and then how that identifies patients, how to score it, and then kind of an overview of the therapy in very broad brush strokes. So my name's Michelle Shiller. I'm a molecular genetic pathologist. I practice in Dallas, Texas. I have a very interesting kind of practice setting and background. I'm at Baylor in Dallas, Texas, and I oversee our hereditary cancer program as the medical director there, so I see everything that comes through the institution from a hereditary cancer perspective. And then my group is contracted to Baylor, so at a national level, I'm the medical director for Genomics and Molecular Pathology Services for PathGroup, which is a large group of pathologists, more than 200 pathologists throughout the United States. And there I drive not only testing algorithms and implementations, but also a lot of educational content and run and conduct the molecular tumor boards. So I get to see how these biomarkers impact practice, not only in large academic-based institutions, but also in community practice and everything in between. I will love to encourage you to ask questions at the end of the session. When you do so, if you could please kindly step up to the mic. We're recording this session for anyone who may want to review it in an on-demand fashion afterwards. So if you could please step to the mic, that will really help us to make sure we capture those questions. So just starting out, and we're going to do a little level set. Like I said, we'll start with broad brushstrokes and then we'll get more specific. So ovarian cancer's prevalence is around the 8th most common cancer in women, with 200,000 women dying from the disease each year. Because early stage ovarian cancer lacks symptoms, most patients are advanced at the time of presentation. And as a result, unfortunately, the mortality rate for ovarian cancer remains quite high, with 80% of patients with advanced disease, which is most of the patients, 80% of patients present with advanced disease, have their disease recur. The folate receptor-1 protein, also known as folate receptor-alpha, is overexpressed in most ovarian carcinomas, and we'll get into that detail momentarily. And as a result, it serves as a predictive biomarker for folate receptor-1 targeted therapy for epithelial ovarian cancer patients. I want to just hone in on that term predictive for a moment, because this field of biomarker-driven therapies is really expanding and moving very rapidly. I also train residents at Baylor, so I forgot to mention that. I'm responsible for their molecular curriculum, and I encourage them to think of biomarkers in the 3 Ps: predictive, prognostic, and predispositional. So this folate receptor-alpha biomarker is predictive of whether or not a patient might benefit from a particular therapy. It does not, at least at this time, there's not information coming out about its prognostic role, and also not understood to be a predispositional one. An example of a predispositional one would be something like BRCA1 or 2. So when we think about the course of epithelial ovarian cancer and what happens with it, I already mentioned, and you're probably aware, that most patients present with advanced stage disease. As a result of that, there's frontline therapeutic approaches, and most of the patients, because they're advanced, end up recurring. With each subsequent recurrence, that disease-free interval gets shorter and shorter. The frontline standard of care therapy is platinum-based chemotherapy, but beyond that frontline care, there are a lot of treatment options that are needed to help service these patients who fit a whole repertoire of different scenarios, not only genetically, but also from their protein expression. So looking more specifically at folate receptor-alpha, you probably know folate. Folate is an important component necessary for normal cell growth and development. Particularly neural tube development is one area that I really always remember the vital role of folate. Folate's a water-soluble vitamin, essential for one-carbon metabolism, so for the synthesis of our vital nucleic acids, DNA and RNA, which are my best friends, that in turn support cell growth and proliferation. It's a GPI-anchored cell surface protein. It binds folate and internalizes the folate by endocytosis. So remember our basic sciences here, endocytosis, providing folate for metabolism. So normal adult tissues express low to no folate receptor alpha. So a normal adult tissue would not express it. And folate intake by cells and tissues is believed to be largely provided by the reduced folate carrier. So comparing folate in normal and malignant tissue, expression of folate receptor alpha, again, it's high during periods of rapid cell division. So cancer is a very highly replicative state, so we would expect to see it, and particularly in certain cancers. Also in pregnancy and in embryogenesis. So it has a role at multiple time points in life cycles. Again, its expression is absent or low in adult tissues, but again, with cancer being a highly replicative state, we see an increased expression of it, particularly in breast, lung, uterine, kidney, brain, and ovarian, which is the focus today, ovarian cancer. Again, little to no expression of it in normal adult tissues and increased in times of rapid cell division, which leads to overexpression. And capturing that overexpression has allowed us to be able to selectively target malignant cells versus normal background in order to deliver effective therapy. Again, that's one of the kind of paradigm shifts as we move into these biomarker-driven therapies is there are improved toxicity profiles because you're actually targeting what's happening at the molecular level with the tumor rather than a more broad generic profile as with the chemotherapy of past. The combination of restricted expression of folate receptor alpha in normal tissue, again, with the overexpression in the rapidly dividing malignant tissue, that separation or dichotomy is what helps to make this an effective therapy. So the therapy we're focusing on here today, and I want to make sure I also just mention at this time, since I've come to this slide, I cannot discuss off-label use of any therapies or other therapies. So any questions pertaining to that, I would need to refer you to medical affairs. But I can specifically talk about the published data on mirvetuximab. The trade name is Elahere. It's an antibody-drug conjugate therapy targeting folate receptor alpha. Now, I want to slow down here for a second on antibody-drug conjugate therapies because this is a very rapidly moving space now in cancer therapeutics. A lot of the things we've been seeing over the past few years tend to be more tyrosine kinase inhibitors, and they function in a different way. Or then there's also things that will go directly into cells. So these are antibody-drug conjugates. They function differently. They dock to the cell based on cell expression and then release an agent into the cell to then effectively have a cytotoxic effect. So that's what this slide is describing to you, is that the antibody-drug conjugate binds to the folate receptor alpha protein and is internalized by the cell, then releases the actual agent into the cell. And this helps to reduce harm to the normal tissue. But the other beautiful thing, and this is why the release of another therapeutic last summer at ASCO got a standing ovation. It has an amazing bystander effect and can impact neighboring cells of that same nature. And that is very significant and helps to really effectively control disease. So the clinical trial looking at mirvetuximab was conducted in patients who are platinum resistant with advanced high-grade epithelial ovarian cancer, primary peritoneal or fallopian tube cancers with high folate receptor alpha expression. I'm going to pause again here for a moment and put on my constitutional hat. Whenever you see a peritoneal primary or fallopian tube primary, that's rare, and you may want to make sure that the provider who sent that case to you has also considered that patient for whether or not they had a hereditary predisposition for their cancer in general, in addition to whether or not they have folate receptor alpha expression. I will also mention, now that I've got your attention on this, that the NCCN guidelines state that every patient diagnosed with ovarian cancer should have germline testing. So just another plug, and make sure. I personally put that in all of my broad genomic profile reports. If I don't know, if I can't tell from what I've received about the patient that testing's already been performed, I just say NCCN guidelines state that every patient with X, Y, or Z should receive germline testing. Please consider this if it's not already been performed. So shifting back, the patient population is high-grade epithelial ovarian, primary peritoneal, or fallopian tube cancers with high folate receptor alpha expression, and we'll get to the details of what that is momentarily. There were 106 patients, and they, again, I already stated the type of cancer they had, and they had seen 1 to 3 prior therapies, so they had already escaped at least 1 line of therapy. Now, the interpretation is expression of greater than or equal to 75% tumor cells with 2 to 3 plus membranous staining. And we'll talk about some other, we'll actually show you some cases at the end so you can see varying staining patterns. The patients received mirvetuximab once every 3 weeks, and the primary outcome was objective response rate. Secondary outcomes include duration of response, adverse events, progression-free survival, and again, remember that's an important variable here, particularly for ovarian cancers, because they are advanced at presentation and have this frequent recurrent cycle that they have. Overall survival and the response of the one thing we've measured for a long time in ovarian cancer patients, and that is CA-125. So the outcome data is favorable, and that is what helped to lead to the ultimate FDA approval with a confirmed objective response rate of around close to 32%, a complete response rate of almost 5%, and partial response rate of 26.9%. The number of responders was 33 in the 106 patient population. Median duration of response was 7 months, right at 7 months, and the range was 1.4 plus 9.8. So overall, 31.7% of these patients whose tumors expressed folate receptor alpha protein at greater than or equal to 75%, 2 to 3 plus intensity, demonstrated a partial or complete response to mirvetuximab, or ELA here. I think it's important, so also want to make this statement here, because I get asked the question a lot, Michelle, how do you keep up with this? Like, I go to bed, the next day I wake up, new approval, what do I do? Has a biomarker, don't have it in the lab, like, you know, it's very dizzying, really. So how do I keep up? I really feel like as pathologists now, making the diagnosis is not, that's just actually where it starts. So once we make a malignant diagnosis, no matter what the primary site is, the next step needs to be, if you don't already know, what do the NCCN guidelines recommend for this patient in terms of consideration for testing? So that transcends any tumor type. Here, with the permission of NCCN, we are submitting to you the recommendations of the NCCN for testing considerations and therapies in ovarian cancer. This is in the tumor itself. Remember, all ovarian cancer patients should be sent to germline testing. So now we're going to focus a little more on folate receptor alpha itself. So again, mortality very high in these patients, so there's an unmet medical need. Folate receptor alpha is one way that we can assess for predicting for a specific targeted therapy, mirvetuximab. The expression is greater than 75% with 2 to 3 plus intensity. And then here's the Ventana assay, is the first FDA-approved IHC companion diagnostic for determining the expression. And we'll go over the details of that here. So the configuration looks like this. You have the assay in-house. You run it with the OptiView detection kit on the benchmark. And then you get your slide and you can interpret it, and we'll talk about and look at different cases. And when the patient has greater than or equal to 75% expression, 2 to 3 plus intensity, then they meet the criteria for mirvetuximab. So this is a qualitative immunostain, uses a mouse monoclonal antibody intended for use in the assessment for the expression of folate receptor alpha on formalin-fixed paraffin-embedded tissue, again, either epithelial ovarian cancer, primary peritoneal, or fallopian tube primary, using the benchmark ultra instrument. And again, it's determined by looking at tumor cell expression, so expression in the tumor cells only. once you achieve the benchmark, no pun intended, then the patient qualifies for therapy. Or maybe it was intended. So it was developed by Immunogen, and this one represents the first folate receptor alpha therapy, so first solution for patients in the marketplace. And I feel like I've covered this, so I'm going to go ahead and advance to the next slide. So this is kind of how you can work it into your workflow, because one burning question, like I said, that I get a lot is, how do you keep up and how do you work it in? Well, I'm fortunate that I'm in a lab that's large enough that we provide a lot of these testing options, but that isn't necessarily everyone's situation. So first and foremost, it starts with us, right, the pathologist. It starts with the diagnosis. And as I already said, I'm going to repeat it because I think it merits repeating. Making the diagnosis in the space of oncology right now is just the first step. And the next step is to see what happens next with this tissue. What additional questions need to be answered to arm our clinical colleagues with the information when the patient follows up so that they're ready to fire. And I'm telling you, if you embrace that mindset and that philosophy, your clinical colleagues will thank you. They want us to help them. They don't want to have to come back and beg us to run a test or this and that. So when an approval comes out, I would encourage you to engage that dialogue with your providers locally. Hey, this came out. Did you see the data? Here, we can either offer it in-house or whatever. Let's have a discussion to see how we can have an agreed upon approach as to how we want to work on this with this patient or with patients with these diagnoses. So we make the diagnosis, and then the next thing that happens, this is at my institution, is that with its high-grade serous ovarian cancer or primary peritoneal or fallopian tube, those being less common, it automatically goes for broad genomic profiling. We run a 500 plus gene panel. That may vary for wherever you are, but it automatically goes to broad genomic profiling. And it's a pathologist-driven algorithm, but it's not a cavalier pathologist just deciding what's going to be tested. This is, again, after having a multidisciplinary dialogue with our clinical colleagues to say, how would you like us to handle these cases? I will also mention the patients automatically reflex for genetic counseling. And then simultaneous to that, on our ovarian cancer cases, we now also run folate receptor alpha IHC. So broad genomic profiling plus folate receptor alpha on the specimens. Now we go ahead and issue that folate receptor alpha result as real time, but we also incorporate it into our broad genomic profile report, because that serves as a global overview as to what the clinical provider is dealing with this particular patient. It assesses for MSI and TMB and all those other bells and whistles. And so we do go ahead and push out that initial result so they know that, particularly if the time is of the essence for a certain patient. But then with the broad genomic profile at the bottom, after we list out any particular mutations detected and resistance and all of that, we have a clinical genomic pathology consultation where we bring it all in together so that, in a case with folate receptor alpha, the headliner would be this patient has folate receptor alpha expression that meets FDA approval criteria at 80%, and this patient's a candidate for mirvetuximab soravtansine, very hard word to say, -GNX to be actually specific. And then we might say what other mutations. Frequently we'll see TP53, very commonly mutated gene in ovarian cancer. Remark about that, whatever, put a little bow on it, and that way the provider doesn't have to, where's that folate report? No, it's all right there in one report. It has all the genetics, they would know the TMB status, et cetera. So again, just to reinforce, and this is suggesting that one way you could report it out is positive for folate receptor alpha 1 is greater than 75% of viable tumor cells. That's not how I report it. I report it as meets FDA approval criteria if it's greater than or equal to 75%, and I have the description of the greater than or equal to 75% lower. But the bottom line, clinical providers are busy. They're in the time management business. It's yes or no, green or red. So it either meets FDA approval criteria or negative, does not meet FDA approval criteria. And that's probably a character flaw on my behalf. I just, as a pathologist, couldn't say 70% or 65% staining was negative because it's stained, and I don't know. So, and I've also had a lot of clinical providers be like, well, what's the cutoff? I don't know. And this kind of is a little bit of PTSD from PD-L1 and everything else too. So I found it better to just say meets or does not meet, and then we can get in the weeds amongst our pathology cells because that's what we love to do, but they really don't want to mess with that. So artifacts can also make the interpretation difficult, and sometimes we have to render not evaluable, though we haven't actually done that just yet, but I guess that time could come. So here's an example, a few different examples, because we as pathologists like to see, well, what does this actually look like when you implement it? So here are some examples of negative, and then some staining but not meeting, does not meet criteria or less than 75%, and then kind of moderate strong staining. We have great expression in the far right there, but again, still not meeting that threshold of 75%. And then here is another negative case, still not meeting the criteria for the cutoff. And then here's a very strong positive case. But I realize that these are perfect world examples, and practicing pathology is anything but perfect world. So we have some other cases to show you. Here's another beautiful positive case. Beautiful membranous staining. It's diffuse throughout the tumor. Really no question as to how much tumor is staining. Here's another example of another positive case. And then here are some challenging cases, which is really the crux of the matter, is what do I do with these difficult cases or abnormal staining patterns? So here's another challenging case, and sometimes it's hard to identify the tumor, particularly once you transition over into the immunohistochemical stain, counter stain. And here we see expression, but it's not quite at 75%. And we have a heterogeneous staining pattern. We have some very strong 3+ staining. We have some 2+ staining. And we have some 1+ in the schema of interpretation. But the 2 to 3+ does not meet that threshold of meeting FDA approval criteria. Here is another challenging case, and you see a lot of staining here. And you're like, wow, in the tray, you're like, that really stained. But you get it underneath the microscope, and as you look closer, you see a lot of cytoplasmic staining. So for this stain, cytoplasmic staining does not count, and it is negative. And of course, you will have cases that have both very strong membranous staining and cytoplasmic staining, but you cannot count those cytoplasmic staining cells. So membranous staining. And then here's another case, and this is kind of reminiscent of perinuclear dot-like patterns. So you see a dot-like staining pattern here, and those brown dots are considered positive. So brown dot-like staining goes in the positive bucket. Cytoplasmic staining gets eliminated out. And then here is another where we have just a lot of staining artifact, the kind of blotchy, non-specific background. Again, those get taken out. We're looking for brisk, membranous, 2 to 3+ staining, the dot-like pattern, or you may also see this, and we've seen this a fair amount. You may see an apical staining pattern, and so that does get counted as positive. Apical staining, brown dot-like or clear membranous, 2 to 3+ intensity, those are all going to go into our positive interpretation basket. Cytoplasmic staining gets pulled out, as does the blotchy, non-specific artifactual staining. So, believe it or not, I'm already at the summary here. Epithelial ovarian cancer remains a disease with high mortality, partially because our patients are advanced when they present and we don't have a good way to monitor early stage disease yet. And given the typical behavior with frequent recurrences, decreased duration of disease-free intervals, we need more therapeutic options for these patients, and mirvetuximab is one potential solution that is expressed in a high number of malignant ovarian cancers, around 70%, and then our cutoff is expression greater than 75%, 2 to 3+. It's listed now in the NCCN guidelines. So remember, when you make that malignant diagnosis, what happens next with this patient's case. And in order to fully consider the therapeutic options, it's recommended to integrate this, especially because it's so prevalent, into the workup of your patient with ovarian cancer, because thinking, well, I need to wait for the oncologist order every time to see if they're going to treat the patient, or if the patient's stage 4, they're going to be stage 3 or 4. So have that conversation early on with your local team and get something going so that these patients can move along the progression fairly quickly. And with that, that summarizes my portion of the talk, and I'm happy to answer any questions. Thank you for your attention.
What do you use for a control for folate receptor, and how is the control interpreted?
We have normal fallopian tube tissue for our control. And it's interpreted with the same criteria as the assay is interpreted. So, and if we have background staining, then we have to repeat the assay.
I might have missed that point, but based on your experience, what's the percentage of high-grade serous would stain positive for folate?
That's okay.
Receptor?
I believe the question is, what is the percentage of high-grade serous that are expressing folate receptor alpha that meets the criteria? It's around 70%, which is what the prevalence reports out. I think in one of the clinical trials is what it showed, and that is what we're seeing. It's very common. So we will see patients who have other genomic aberrations, TP53, P10, something like that, because we have a broad genomic profile and also have folate receptor alpha expressed.
Okay, well, thanks a lot. And also, what's the percentage of labs that have this immuno available?
What is the percentage of labs that have immunohistochemistry available for folate receptor alpha? I don't know what other labs offer folate receptor alpha testing in the US. I know that my lab does, and I don't want to misrepresent and seem like I'm partial to any one particular lab. So I don't know who all is offering that right now, but I'm sure the medical affairs team could answer that question. I know that there are definitely several options to choose from.
Sure. Okay, thanks a lot.
Yeah, thank you so much.
Hi, can you comment on the this IHC assay performance compared to the genomic profiling of folic acid expression?
You mean in terms of detecting a mutation in folate versus, well, you know, that's a great question. What I can tell you, folate is on our panel, and I have not yet seen a co-mutation in the folate gene and expression of the protein. But it wouldn't call it out. It wouldn't bring it to the front line, because ours is designed to identify targets for therapy. And since the indication's based on IHC, I'd actually have to look back. There may be some lurking in there, but that's a great question. I don't fully know the answer. I'm sure that there are several that have both a mutation in folate as well as the expression.
Okay, thank you. And another question is, this IHC assay can be performed on the metastatic tumor as well?
On metastatic sites?
Yeah,
yes,
metastatic.
Yes. There just needs to be already diagnosed as originally a primary Mullerian, ovarian, fallopian tube, or peritoneal.
Okay.
Yes.
Thank you
So it could be metastasis somewhere
Thank
else. Yeah.
I have a question about therapy. Is there a good linear correlation between the levels of the receptor detected by immunohistochemistry and response to therapy? Because sometimes that relationship is not linear.
Right. I don't have the data on that. I know that they're looking at that, and that's a great question for medical affairs, and it definitely makes you think, what about those patients who have less expression, and of those patients, which ones did or did not respond? That's something that they're looking into more thoroughly, but I don't have all of the discrete data on that.
In fact, you could see sometimes paradoxical responses in which lower levels makes the cell more sensitive to blocking because it's relying on fewer receptors.
Right, yeah, and we see that in multiple different types of tumors. So yes, very good question, thank you.
I'm sorry if I missed it, but did you talk about the minimum number of tumor cells that has to be present?
You know what? We did not talk about the minimal number of tumor cells. I believe it's 100. We don't ever have an issue, but
Okay.
100 is pretty standard fare. So
Thank you.
it's a percent, so 100.
Hi, thank you for your lecture, your presentation.
Thank you.
The histology from these 106 patients was only high-grade serous.
Yes.
So we don't have yet application for other
Right.
high-grade endometrioid, not yet.
Correct. So the question is, what about histology other than high-grade serous ovarian carcinoma? And the answer is, I don't believe the label is for beyond high-grade serous, but that would be a question to confirm with medical affairs.
Okay.
I don't think that it covers endometrioid subtypes
Okay. Thank you very much.
or triple MTs or,
Okay.
yeah.
Thank you.
Sertoli-Leydig and so on. Okay, I think that that's all the questions. So thank you so much.